You've spent hours stabilizing a critical patient, but after they're sent home, how does the central system track the intensity of care your team provided? There is a specific pipeline for translating human effort into data. It moves from the patient's bedside into your discharge summary and finally into MyCMX. Once entered, the software automatically generates two codes that define the admission, the DRG and the SOI. This makes the discharge summary the single most important bridge in the hospital. If the work isn't recorded there, the system effectively thinks it never happened. This first code, the DRG, serves as a broad category label. You can think of it as the title of the patient's stay. Its job is to group patients with similar conditions together to set a baseline for the resources they'll likely need. It's the system's way of organizing the ward by the main condition being treated. However, this broad label is blind to the details. It cannot see unexpected complications, the severity of symptoms, or a patient's sudden clinical deterioration. To this specific algorithm, a patient recovering quickly from a mild infection and a patient fighting for their life with that same disease look exactly the same. While this code identifies what disease was treated, it leaves out the actual amount of work the medical team had to do to reach a successful discharge. That's why we have the second code, SOI. If the DRG is just the title of the stay, the SOI is the storyteller. It provides the complexity score for the admission. The system calculates the score by looking for 4 specific details: underlying comorbidities, new complications, major procedures, and any escalation of care, like an emergency move to the ICU. There are 3 distinct levels, ranging from level 1 for minor cases to level 3 for major complexity. Each step up signaled to the hospital that a patient required a much heavier workload. This is the only metric the hospital has to differentiate a routine, standard admission from a complex, resource-heavy struggle for a patient's survival. Let's look at 3 different patients to see how this works. They are all admitted to the ward and placed in the exact same category, medical pneumonia. Patient A is a standard case of pneumonia with no other issues. Because the care is straightforward, the system logs them as a level 1 complexity. Patient B has pneumonia as well, but they also have uncontrolled diabetes and develop sepsis and a kidney injury. These extra layers move them up to level 2. Finally, patient C crashes into septic shock, requires a ventilator, and is rushed to the ICU. Because of the intense effort required, the system assigns them a level 3. Think about the difference in medications, monitoring, and staff hours between these 3. Yet, on a basic report, their category code is identical. Clinical reality can change in an instant. The SOI level is the only way to ensure the software recognizes that the workload has increased. But there's a catch. The MyCMX software cannot see the patient, and it cannot read your mind. It only knows what you tell it. This is the discharge form, the only place where clinical complexity is officially recorded. Note the specific lines for complications and comorbidities. If these sections are left blank, the system defaults even the most complex patient down to level 1. When documentation is missing, hours of intensive life-saving care are recorded as a basic, uncomplicated shift. This makes your actual workload invisible to the people who plan the hospital's resources. Don't let your hardest work go invisible. Make it a habit to document every comorbidity, complication, and procedure before a patient leaves the ward. This data is what the hospital uses to justify its annual budget. By documenting the full story, you ensure the system accurately reflects your team's productivity, securing the manpower, equipment, and funding you've actually earned.